cataract again with macular problems, and is my pre-op protocol correct? And I think the previous speakers have elaborated upon so many macular pathologies and the role of retinal surgeons in them, or for that matter, role of cataract surgeons in working along with retinal surgeons and taking better care of our patients. And the most important message is a good pre-op evaluation, which involves doing a good retinal as well as a complete evaluation. What we often forget is that we have to treat the patient as a whole. So we are looking at the entire eye as a whole, not just cataract or macula or any absolute anatomic segregation of eye. You look at the patient as a whole, and Dr. Savalan had shown the importance of OCTs or pre-op OCTs cases. And the most important message that he had also given was, if your patient's visual acuity is not corroborating with the grade of cataract, that means you need to look at what else is happening in the eye. And so, what are the more important parts in any pre-op protocol? Number one, look at the systemic parameters of the patient. Is the patient systemically stable? Is he an uncontrolled diabetic? Because that can have adverse effects. Look at the zonular status of the lens, and more importantly, look at refractive surprises. Take a meticulous history, correlate vision. Meaning thereby, if your vision is not correlating with the grade of cataract, means you need to look at what else is happening. Look at the retina or look at the macula. So a lot of macular pathologies can go on to have an effect on the outcomes of a patient, and it's important for us to look at the retina and the macula not only in terms of offering treatment, but also in terms of prognosticating and explaining to our patients the visual outcomes which can happen. Because like we have discussed, patients will be expecting a visual acuity of 20/20 post-surgery, but that can be hampered by an underlying macular pathology. And as surgeons, it becomes important for us to explain to our patient what is an underlying pathology, how it can play out in future, and what can be its effect on the future prognosis. We have had discussions on macular edema, epiretinal membranes, macular holes, vitreomacular traction, and diabetes. So I'll just show you a few cases where it was important to look at the retina for us to determine the future outcomes of the cataract surgery. So a comprehensive evaluation, a need for it can obviously not be understated. Visual acuity, slit lamp, look at optic nerve status in the terms of RAPT. Check for any neovascularization. So if there is any NVI or NVA, important for us to do a gonioscopy. See if there is underlying vein occlusion or any neovascular glaucoma which is developing. IOP, fundus examination, and obviously OCT and angiography or a B scan when required if you can't visualize what's happening. So if you have a cataract where you cannot visualize the retinal details, it becomes important for us to at least get a pre-op B scan done to see if there is any underlying retinal pathology which may adversely affect the outcomes. Moving forward, so this was one patient, and these are patients who were referred to us post-cataract surgery. This is a patient who had undergone a cataract surgery, then came to the retina clinic with an unexplained decrease in vision, and what this patient has is an obvious macular hole. Another patient was a known diabetic, but when we did an evaluation, we found not only that the patient have a mactal or a parafoveal angioedema, but also had this vitreomacular adhesion over here. These are all patients who need a concurrent management of the retinal pathology too. Now this was one more patient, 2040 advised for cataract surgery, but what this patient also had was a pre-ILM hemorrhage, and along with the pre-ILM hemorrhage he had this small, very subtle white centered hemorrhage, or what we call a rod spot. We got this patient examined, and this patient surprisingly turned out to be a patient of CML. So we were the first ones to actually diagnose CML in this patient, and this patient, a visual acuity of 20/40, had been advised for a cataract surgery, but a retinal evaluation revealed an underlying blood dyscrasia, and that's why it's important for us to look at the macula, look at the retina as part of our routine pre-op evaluation for all of these patients. Again, patient become with cataract with multiple diffuse fine stellate KPs, no cystoid macular edema or OCT, no synechiae. These are patients of Fuchs uveitis syndrome. Again, we need to just tell that sometimes post-cataract surgery they will have a problem of persisting floaters. So the importance of a pre-op evaluation is not just in prognosticating, but also in helping our patients in their future management and in guiding them as to what to be done next, and as to also guide them on their expectations post-cataract surgery. So look for signs of inflammation. We just had a talk by Dr. Vishali ma'am where we were discussing about the role of cataract surgery in post-uveitis. But if your patient has had a past history of ocular inflammation, has had a complicated cataract, look for any persisting signs of inflammation. If there is active inflammation, usually a cataract surgery can be deferred. If it's an absolute emergency, you may do it under cover of steroids, but ideally at least a 3-month quiescence post resolution of inflammation. So one of our patient was referred for cataract, but had actually a peripheral spontaneously attached retina, plus peripheral retinal necrosis over here. Another scenario where it becomes important, probably we could have discussed about diabetes and its role in cataract later on. But the point over here is that it becomes important because you may have these underlying pathologies. diabetic macular edema can worsen post-cataract surgery, so you may probably either treat them with a concurrent anti-VEGF agent or a steroid implant also along with the cataract surgery at the same time. So in a nutshell, take a good history, correlate vision with your cataract grading, and a complete ophthalmic evaluation has to be a part of our pre-op protocols. Thank you so much.
Thank you very much.